Close. Okay, welcome everyone to our lecture series, Unity Through Knowledge. Today we will have the second part of pediatric anesthesia, and also it will be presented by Dr. Mohammed Ahmed Ghazi Suliman. The first part gave us an overview about the principle and tips of pediatric anesthesia, and today Dr. Mohammed Ahmed Ghazi Suliman will walk us through case scenarios in pediatric anesthesia emergencies and resuscitation. Without overdue, let's welcome Dr. Mohammed Ahmed Ghazi Suliman.
شكرا حياك كتر خيرك. السلام عليكم يا شباب. برضو داير أشكر تاني الرابطة للدعوة وإن شاء الله تكون دي مادة مفيدة اليوم. طيب, today's presentation is about case scenarios in pediatric anesthesia, emergencies and resuscitation. Emergencies بالتحديد لأنه pediatric anesthesia as concepts was covered in the previous presentation. This time, what we are going to do is follow on and build on from what we did before. طيب, anyone who's logged in, can I just ask a very quick favor? بس عشان تساعدوني بعدين في البرزنتيشن دي, عايزكم بس بالتليفون بتاعكم تعملوا سكرين شوت هسه للكيو ار كود ده في اللحظة دي. تمام؟ And shortly we will just do a quick poll. فلو عملتوا بس سكرين شوت للكيو ار كود دي بتوديكم لويب سايت وطوالي بتقدروا to start a poll. التصويت ده بعدين هحتاجه انا في البرزنتيشن لقدام, فعليكم الله بس تاني another 5-10 seconds وانا واصل. اوكي طيب, اي زول دخل عليكم الله try and start this poll straight away. المفروض تكون لكم ظاهرة وتبدو الانسرز immediately. Just choose one of your answers please. اوكي تمام. بس استعجلوا معانا شوية يا شباب عشان عندنا برزنتيشن طويلة ما قدرنا نأخر الناس. طيب, أظن ما يكفي كده. طيب, معظم الناس اللوجدين انترستنجلي هم في دول الخليج, يعني جيراننا هنا قطر, السعودية, الإمارات. ف يعني في شوية ناس في السودان وناس في أمريكا. ناس أمريكا ده ما عندكم علماء بهناك يا جماعة, أنتم ما شاء الله داخلين معانا. فعلى كل حال أنا this was for my own purpose to try and get an idea about who is actually logged in and where they are. طيب, زي ما قلت البرزنتيشن today will build on what we discussed last time. I will not focus on theory. My aim today هو إنه to try and focus on cases to make it more interactive. إن شاء الله تذكركم بأحداث وكيسز أنتوا شخصيا عملتوها اشتغلتوا فيها, وبالتالي to try and reinforce the knowledge and the memorization of the techniques we will discuss today. What I cannot and it's impossible to do is to give you a full overview of all the separate pediatric anesthesia emergencies. Even books cannot do that. Pediatrics is a fantastic specialty. Kids come in different shapes and different sizes. Every single day we come to work, we may be faced by a different kind of emergency. So it's impossible to cover all of this in a single presentation. لكن إن شاء الله this presentation today والفاتت مع بعض ادوا صورة عامة عن our approaches. And الحاجة الثانية برضو, this is not a case presentation to discuss the courses, the Pediatric Advanced Life Support course. I request and suggest from each and every one of you to attend a separate pediatric advanced life support course. This is for the minor details of resuscitation techniques. طيب. What are the most common themes when we are talking about pediatric anesthesia emergencies? I want to emphasize it is respiratory, it is respiratory, it is respiratory. Pediatric anesthesia is primarily about airway and gas exchange. If you fix these two things, you will more or less avoid 80% of all of the common emergencies that happen in the OR. Why is the issue around airway and breathing? Because of the topics we discussed last time, mainly that children have unique airway anatomy. They have a very large occiput and a large head. The laryngoscopy can be a bit more tricky than they are in adults. You have very loose and delicate tissues, a floppy leaf-like epiglottis that can sometimes fall on your laryngoscopy blade and occlude your glottic opening. The trachea itself has a very interesting shape. So it's wide at the inlet, but it then follows a very conical and narrowing trajectory. So you may find it easier to introduce the tube, but as you pass it down the trachea, you may actually be faced with a little bit of resistance. And that's why pediatric anesthetists historically were so obsessed about correct sizing of the tube, about cuff pressures, etc., because we worry about subglottic stenosis and issues with the airway further on. Children also bring up their saturations quickly, but they also drop their saturations quickly. And the reason for that is they have a very low functional residual capacity in the context of their body shape and size. And they, at the same time, this is balanced by the high oxygen consumption that they have. So the reserve is low, but the consumption is high. And therefore, they can precipitate a desaturation episode very quickly. Cardiovascularly, children have fragile hearts, and by fragile, I mean they have a fixed capacity to deal with a hemodynamic instability. كيف؟ لأنه they are usually unable to mount an adequate response, especially in the neonatal period and early infancy. The primary way infants and neonates can cope with hemodynamic instability is by increasing their heart rate. But that the heart, as we know, and cardiac output is influenced by multiple parameters. Only one of these is heart rate. It's also influenced by preload and filling pressures. It's influenced by afterload and SVR. It's influenced by contractility. And so all of these things in an adult heart can be changed and tailored to cope with changes in the circulation. However, in neonates and infants, all you can really do is increase the heart rate. And this is what neonates do. Obviously, in anesthesia, we can then give fluid boluses, give something in our epinephrine to try and boost up the SVR. But these are our own exogenous, so external interventions. Children by themselves, they are not able to do that alone. Now, the more common also theme of emergencies that we see in pediatric anesthesia is now increasingly around the aspect of pharmacology, drug dosing, and prescription errors. And this is really a big theme when it comes to modern healthcare, especially in countries where incident reporting is very common, where it's actually mandatory to declare and notify these incidents. And mainly because also the drugs we use in pediatrics are primarily weight-based. So there's a lot of calculations, a lot of decimal points. So sometimes people miss the fact that there is actually a prescription error here. And we see that more or less on a weekly basis, prescription errors for some simple drugs like paracetamol. However, there are some major issues sometimes, the way we dilute epinephrine, vasopressors. In cardiac anesthesia, we have some very potent drugs, vasodilators, and these can sometimes be diluted way, and that can be catastrophic if given to the patient. You know, the doses we use in heparin, for example, they can come diluted in different when it comes to pediatrics. Usually, having two people cross-check each other is very important. So, just to go on and start some case discussions, this is a first case, and I'd like everybody to think about it whilst we are reading through it. A 4-year-old, 16-kilo male, so a good weight, had an uneventful adenotonsillectomy in the OR, and then you go ahead as the anesthesia, extubate them deep. And this is a routine way that we extubate children who've had airway instrumentation. We do it usually deep to avoid coughing and bucking and causing further bleeding in the airway. It's a skill, it's an art. There is ways to do it well, and there are ways to do it badly. Anyway, so this kid is extubated, and then immediately after extubation, you see that the child is developing a very labored breathing with stridor, noisy inspiratory effort, and his oxygen saturations, as commonly happens, start to plummet, start to fall very rapidly. You get very stressed, your heart rate goes up, you start to feel what the hell is going on here. And then you look at the monitor quickly, you see that the heart rate is high, the saturations have fallen from the mid-90s to the low 80s, and they keep falling in front of your eyes. You're looking, what can I do? You start to apply some oxygen via a face mask. You are thinking what else can happen. So, based on this scenario, can you please go back to the poll that I showed you before, and I would like you now to tell me to choose which one of these is the correct answer. What is the most likely diagnosis in this scenario? Again, I'll give you another 10 seconds or so. Please, when you answer, don't think too much. Just answer instinctively what you think by instinct is going on here. Okay. So I've closed the poll, and fantastic. Laryngospasm is the correct answer, and I'm glad people have noticed that this is actually what's going on. Okay, so we are not finished yet. Now, the next question is, what do you think is the best approach for this kid? Again, just choose your instinctive answer. Okay. Let's see the results. Very good. والله يا جماعة انتم ما شاء الله ما داري لكم presentation انتم. Very good. والله يعني I'm pleasantly surprised that everybody is really, a lot of you must be doing quite a lot of pediatric anesthesia. So I tried to trick you in this choice because in the beginning, I gave you the option of giving IM sucks. Why would you give IM if you've just finished the case and you clearly would have already had IV access throughout the case? So anything IM just doesn't make any sense. So the answer is one of two options, the second or the third. So this is clear-cut laryngospasm. most laryngospasms break with just a little bit of PEEP. Good firm PEEP by itself will break the laryngospasm. And you just have to be a little bit patient. If for any reason it doesn't break, then a little bit of IV propofol, and we're not talking about a huge dose here. You do not want to re-anesthetize the child. You can just give a tiny whiff of propofol and the laryngospasm will break. So I'm glad you all chose the correct answer. And this is essentially what I have tried to summarize here. Basic airway maneuvers, suck the airway if there are any secretions, if there are any signs of blood left over by the ENT surgeon. Make sure the airway is nice and patent. You can also put an oropharyngeal airway, a Guedel airway, to just maintain that airway whilst you are applying PEEP. A good, decent amount of CPAP with the anesthetic mask. I personally really favor Jackson Reese sedatives because it really gives me a feel of what the patient's sort of respiratory effort is like. So it gives me feedback, immediate feedback compared to the circle system. Deepen anesthesia with some propofol if you require, only a tiny amount. If for any reason you're really unlucky and you do not have IV access, you can obviously give IM sucks in a very desperate scenario as a rescue technique. And if things really go badly, then prepare for reintubation. But this is a very odd scenario if you have to reintubate a child because of straightforward laryngospasm. Maybe there is something else that you are missing. So having to reintubate is a little bit odd. Now, I put this last statement, coronoscope, because in people who trained in Europe and the UK and Ireland, there's a court of law called the coroner's court. And this is usually where medical legal cases are seen and witnessed. And there have been incidents in the past where children who've had adenoidectomies or adenotonsillectomies have essentially had severe laryngospasm and complete occlusion and blockage of their upper airway, desaturated without it being fully recognized, usually in PACU, in the postoperative recovery area. And these children then demise or ended up having, severe hypoxic ischemic encephalopathy. And it turned out that the reason is there was a little bit of clot left over just above the airway, above the vocal cords that were later on missed. And that's why now routinely, what we tend to do as part of our training, we've always been shown that have a final laryngoscopy yourself before you wake up the patient. So, we all trust our surgical colleagues, but as a routine, before you start to lighten the anesthesia and to wake up your patient, just have a very quick, gentle laryngoscopy to make sure there are no, secretions, blood clots left over behind by the surgeons before you wake up, to make sure you're absolutely in the safe place. So this is case 2. It's about a 2-year-old, 12-kilo child who is previously fit and well, suddenly developed persistent coughing out of the blue. يعني ما في any other prodromal symptoms, ما في any subacute onset. This is all out of the blue, completely sudden. The child is brought to the hospital, is reviewed in ED, and your anesthetic opinion is required. You come down, you see the child, they see that the child is tachycardic with a heart rate of 150, breathing quite fast with increased work of breathing. Saturations are in the low 90s on room air. And the child is so upset, very distressed, crying, is fed up. People are poking him with needles. So anyway, you cannot get a non-invasive blood pressure out of him. Then later, you also assess generally what the child's respiratory effort is like, and you see that she is working quite hard in mild respiratory distress. You auscultate, she allows you to auscultate, and you find that there is decreased air entry on the right side of the chest. So based on this scenario, do you think this is an onset of a lower respiratory tract infection? Do you think with her coughing and the very loud coughing that she's doing, this is croup? Or do you think this child aspirated a foreign body. So just go back to the presentation again. Okay. Fantastic. So I think the history gave it away. Like most things, it's all about the history, the history, the history. So this is a very acute onset scenario, which means that the likelihood it's going to be a foreign body aspiration. So what would be your most appropriate anesthetic induction technique in this case? So these are all fairly similar wording, just careful to notice the differences. في ناس يا جماعة بتجاوب بتغير راية. الموضوع ما امتحان بس I just want you to instinctively answer. Okay. Very good. Fantastic. So 60% of you have answered correctly, and we will talk about why intubating and paralyzing is not a good idea, and at the same time, why an IV induction is also not a good idea. It's not wrong, but not our preferred option in this case. طيب. So you go and see the patient, you do a quick rapid assessment, you take a history, and you realize that the child was left unattended with small parts, with some small toys, and Lego is always the classic offender. ولا حتى some children are left with small coins, metal money, and there you go. You always, when you pick this up in the history, you realize this child has tried to put it in their mouth and then inhaled it. Physical examination may not be that useful in this scenario, but there may be some subtle sort of focal signs or unilateral signs, like I mentioned in the history. The key thing that I want to pass on here is that some foreign bodies are not too bad. They need to be removed, lakin it's not a matter of immediate urgency if the child is well. Lakin some other foreign body, it's absolutely critical to remove them as soon as possible. لأنه they can cause major catastrophic airway or even great vessel erosions. And what I mean here are peanuts, and even worse, lithium button batteries. الليثيوم بطن batteries ديل بالذات they are an absolute disaster. ورجاء خاص anyone here who has children أطفال صغار, make sure you remove these buttons from your homes. الليثيوم بطن batteries ديل الصغار العاملات كده زي القروش الصغيرة تحت الحديد دي اللي هم round in shape, وبطاريات الصغيرة اللي بتتخطى ورا الساعات والحاجات. They are very, very dangerous. We have had children who swallowed them and they eroded through the esophagus and the innominate artery and caused catastrophic bleeding, and the children died. We had children who inhaled them They went into the airway and they eroded through the airway, caused the tracheoinnominate fistula, and then the child bled into their lungs and died. So these button batteries are extremely unsafe, and in some developed countries, they are actually starting to remove them from the market. Please, as if you are an on-call anesthesiologist and an ENT or a pulmonology colleague comes to you and say, I suspect this child inhaled peanuts. Peanuts are also very irritable, or lithium button batteries, you have to act very, very quickly. The main other point is where the blockage has happened matters. The more proximal it is, the higher it is in the tracheobronchial tree, the more significant it will become for airway flow, for airflow and airway anatomy. So if this foreign body is in the left main or more usually in the right main, then it's likely to cause more symptoms, more abnormalities than if it is further down the bronchial tree into the segmental bronchi. The issue is, if it's more proximal, then technically it's easier to retrieve. Lakin if it is more distal, it's more technically challenging to retrieve. So it is a balance. Don't forget the basics of anesthesia pre-assessment, and mainly here I'm talking about fasting times. I'm talking about doing a comprehensive cardiovascular and respiratory assessment. Explore the airway, make sure that this airway is not going to be challenging, especially in the context إنه ده حيكون a shared airway case between you and the pulmonologist or the ENT surgeon. So you need to be comfortable. You can intervene and rescue this airway if there are any issues. If this is a difficult airway from the signs and the child is syndromic, then you really need to be thinking hard about the approach both of you will use. Look at the child's chest X-ray. It may give you some clues about where the foreign body is lodged. Lakin ultimately, some things are not radio opaque, so they may not actually show on any X-ray imaging. And take your time to discuss and communicate with your ENT and pulmonology colleague exactly what they are planning to do and what using. لأنه this is the time when it really matters for you to both be very clear about your roles and what you will do when something happens. You do not want to have this conversation in the middle of a desaturating child, in the middle of the case with the patient asleep. So find out what rigid bronchoscope they will use. Find out if this rigid bronchoscope has a side port. Find out if this side port will fit in your universal connector. Find out how much flow you can give. Decide with him, are we going to do this case using a volatile anesthetic, whether we will do it as Tiva. Find out with him what he expects the difficulty will be. Discuss with them in the event of a desaturation, what will we do? Are you going to intubate? Will I intubate? Are we not going to wait, but you'll come out and let me back the patient? You have to go through all of these details together so that you're all comfortable. There is a clear plan, at least mentally, for both of you to action if there is an emergency. So what I usually do in these cases is that it's very important to maintain spontaneous ventilation. لأنه it allows for the airway tone to be maintained. And secondly, it does not require IPPV. Why do we want to avoid invasive pressure ventilation in these children, whether it's via tube or manujet ventilation or anything like that? It's because you do not want to dislodge the foreign body further down into the lungs. Like I said, the further away it is, the harder it is to pull out. So if you maintain spontaneous breathing, the child will breathe by themselves. You need to keep them sedated and asleep. You need to keep them deep enough to allow for the surgeon to put these very stimulating instruments. So how do you do that? There is a technique to it. You can use inhalational techniques. You can use Tiva. So inhalation is simply using oxygen, air, and SIVO mix, but you must locally topicalize the airway, the vocal cords with lidocaine. And once you do that, the whole airway becomes completely desensitized, and that gives the surgeon the opportunity to insert his instrument without the child coughing and bucking too much. If you don't do that, then that means you have to very much deepen the child to a level where they will become apneic, and then you've defeated the point. So with local anesthetic helps you is maintaining a moderate level of depth of anesthesia to allow the patient to not be aware, but at the same time to be breathing spontaneously. Ketamine may be a very good option also in this scenario. I personally use a propofol infusion, and I run it as mics per kg per minute, usually anywhere between 250 to 300. The smaller the children, the more they need. So I gas the patient down with oxygen, air, SIVO. I get some IV access. I try not to get the IV access before when the child is awake, because that causes them more distress. They're already scared, and I do not want to cause them any more airway issues. So I do it after the child is asleep. I get IV access with the baby asleep on some inhalation or on some volatile, and then once I get the IV access, I switch off my volatile, but I keep the fresh gas flow on 100% oxygen, and I connect a propofol infusion, which is already set up and prepared, and I start the infusion at around 250 mics per kg per minute. I also have a small 5 ml syringe with neat propofol in it as rescue boluses in case the child needs to have a little bit more. I then spray the vocal cords, so I do a quick laryngoscopy, spray the vocal cords with some local anesthetic, and I try to gently go beyond the vocal cords and spray more with some local anesthetic, and that way the whole airway is topicalized. Be prepared, so get your skilled assistant, your technologist to have all the appropriate side tubes, blades, laryngoscopes, just in case you then have to either yourself or the ENT surgeon, you have to intubate this child. So moving on, case 3, we have a 3-year-old ex-prem, now 12-kilo child. So they've developed quite well. He's scheduled for an open inguinal hernia. So you've done all your pre-op assessments. There is no concerns at all. You bring the child to the OR. You induce them. They already have an IV line in situ, so you induce them with IV propofol. Then you insert an LMA, and then you turn them over on their side and you do a caudal. The caudal is a little bit tricky. You get it on your 3rd attempt, and you're fairly happy with it after that. And then you reposition them. But straight away after you reposition them, you notice the child suddenly has a seizure. That's very scary, very worrying. You're not sure what exactly is going on. You quickly look at your monitoring and vital signs. The child is tachycardic. Their blood pressure has dipped a little bit, and they've started to desaturate during the seizure. You only have an LMA and nothing else. So you examine the ECG trace a little bit more, and you can see that there's a broad complex ventricular tachycardia with frequent ectopics, and the hypotension is getting worse. So based on this scenario, what do you think is the probable etiology for these features?
Local anesthesia.
Last.
Mm-hmm. Okay. Yeah, salam alaikum. ممتاز. So this is a classic local anesthetic toxicity. أنا بالمناسبة أنا شكله الأسئلة دي مسهلة شديد. I should make it more difficult next time. لكن والله this is exactly what is يعني the whole aim of this presentation today. It seems إنه الناس are clearly يعني their mind very aware of these issues, and this is a great thing. So local anesthetic toxicity is not common, thank God, لكن you have to have extreme vigilance around it, especially when you're performing regional anesthesia. Um, there is a very high chance of intravascular injection of local anesthetic in children, especially in well vascularized areas. And depending on where you're doing the block, increases the risk. So areas where central neuraxial blocks have a higher risk than peripheral nerve blocks, intercostal blocks, paravertebral blocks. These are all places where brachial plexus blocks. These are all places where you may have a higher chance of local anesthetic toxicity because of the prevalence of the neurovascular bundle in these areas is higher than in other areas. So you are likely to cause an intravascular injection and end up with a local anesthetic toxicity. It's very important to also recognize local anesthetic systemic toxicity is not necessarily to do with the total um, dose that you use. You could use a very safe dose, but the fact that it was partially absorbed systemically is what causes the local anesthetic systemic toxicity. And you can actually sometimes use an overdose and not have any problems because you've used it on the airway where there is barely any significant systemic absorption, while you sprayed it on a mucosal surface, so there is no risk. ولا a surgeon infiltrated under the skin on subcutaneous fat. So just be very clear in your mind. Local anesthetic systemic toxicity is not just about the dose. In fact, it's in my mind, it's nothing to do with the dose. It's to do with the likelihood of systemic absorption. I'm not saying here go ahead and use big doses. What I'm saying is be more thinking about where your needle tip is. And this is why nowadays the importance of using ultrasound when you do regional anesthesia. And ultrasound should be a needle visualization, not just a needle tip visualization technique, not just a landmark technique. If you use it well, your chances of developing LAST is extremely rare. If you use it badly and you end up with intravascular injections, then you can see this. So LAST, the most important about it is thinking about it, recognizing it. If you do not think, if you do not suspect this is what it is, some people can try and take you down a different path. Oh, this patient needs a fluid bolus, a fluid challenge. He needs, he's having broad complex dichotomy. Maybe there's some underlying cardiac issue, unrecognized rhythm abnormalities. Let's bring the DC cardioversion. But and that can sometimes take you away from what actually is going on. So you have to have suspicion, a very low threshold to suspect that this could be local anesthetically induced. And then once you are on the right path, treating it is supportive. So number one, you need to support the airway and the circulation. And these are doing all the basic things to keep the air going in and out and the blood going round and round. دي الحاجات الأساسية. And then if the patient is still fitting, you have to try and stop the seizures by giving rescue benzodiazepines. You have IV access already, so you go ahead and give some IV midazolam. 0.1 milligrams per kg is usually more than enough, but do not delay the definitive treatment. And the definitive treatment here is giving a lipid emulsion therapy. Most hospitals use 20% intralipid, ده الاسم التجاري بتاعه. And it's a very simple math formula, 1.5 mils per kg as a loading bolus, and then you run at 15 mils, so يعني 10 مرات the volume, 15 mils per kg per hour as an infusion. You can repeat the bolus again in about 20 minutes if you require. Like usually, if you are quick, then you see a very rapid recovery after that. P2 issues. A lot of us may want to do, we are tempted to do regional anesthesia and blocks without necessarily making sure we have access to intralipid. I don't think this is safe, because if you run into problems and you have lost, there is no way to treat it without intralipid. So you can find yourself in a true emergency without the antidote, and this is dangerous. The second thing is, I've come across many people who think because propofol is an emulsion, you can use it as an alternative to intralipid. This is false, and this is not true. This is not accurate information, and actually, it is absolutely not effective. In fact, it can make the situation much worse. So propofol is a 10% emulsion. Intralipid is 20%, and to gain the same amount of utility and effectiveness in terms of the intralipid requirements, you need to use a huge amount of the drug, and that can precipitate a major hemodynamic instability in the patient, in the child. So we do not advocate the use of propofol as an alternative to intralipid. And you'll be surprised how much this is like an urban legend, and most people out there believe that it can be used as an alternative. Right. So this is another case, and I think this is the last case we will discuss. I will talk about a few other things, but not necessarily do a major discussion on them. This is a 6-month-old, 6.5 infant. Because background, I thought I will bring a cardiac case. This child has an unrepaired tetralogy of Fallot. So they present to the hospital in an emergency with a suspected strangulated inguinal hernia, and they require urgent surgery. You do a quick preoperative assessment, which is fairly unremarkable. The baseline saturations are in the mid-80s. So this is what is normal for this child. So you take the child to the OR, you perform an IV induction. They already have an IV line, and you give fentanyl 1 mic per kg, propofol 2 milligrams per kg, and rocuronium 1 milligram per kg. You intubate the trachea uneventfully, and you maintain your anesthetic using an oxygen air SIVO mix. You decide, very logically, to keep the end-tidal SIVO in a fairly sort of lowish concentration to avoid any unnecessary hypotension, and that's fair enough. Like shortly afterwards, you realize the infant suddenly became cyanotic. They desaturate, their saturations drop from the mid-80s to 55% very quickly. And even when you put them on 100% FiO2, the SATs only come up to 65. Other vital signs, the child is tachycardic, a heart rate of 180, the blood pressure is 65/35, so not great really, and the SpO2 is 65%. So what do you think is the likely cause of the desaturation in this scenario? Great. عليكم الله القلب عنده برونكيال انتوبيشن ولا برونكوسبازم منه؟ علينا حسه دي. This is clearly a cyanotic spell. يعني the fact that this patient has an unrepaired tetralogy of Fallot is a clear indication that this is most likely going to be a cyanotic spell. It's also good to keep an open mind لأنه not always things are this easy in real life. لكن better to, common things are common. So knowing this, what is now the most appropriate drug combination that will help reverse the hypoxemia? Okay. طيب. Very good, very good, very good. الناس اللي قالوا روكيرونيوم وفينايل افرين, this is not the correct answer. I understand where you are coming from, لكن I suggest you do more cardiac. If you do more cardiac and you come through this scenario, you would have not chosen this. لكن I understand. I understand why you chose that. The correct answer is to give fentanyl and phenylephrine. طيب, why is this the correct answer? We need to understand the physiology of what happened to understand how we treat it. طيب, what is the hallmarks of tetralogy of Fallot, the physiological and anatomical hallmarks? So it's called tetralogy because it's constituted by four major features. Number one, there is a large perimembranous VSD, so intraventricular septal defect, a big one. And with that as well, the outflow tract to the right ventricle is tight. It's partially or totally obstructed, depending on the spectrum of the severity of the tetralogy of Fallot. Lakin at least there is significant stenosis. The right ventricle, because there is stenosis to its outflow tract, that's why the ventricle muscle is hypertrophied. So it's a thick, restrictive, small RV chamber full of muscle. The wall is significantly hypertrophied. And on top of that, because there is a big VSD, that means in infants, in the fetal period, the aorta the heart is not fully septated. The two ventricles are not fully septated, يعني separated. فعشان كده the aorta, left-sided, the outflow tract, starts to shift a little bit towards the right side, and what we call an overwriting aorta. An overwriting aorta دي ذاتها is along a scale. يعني السكيل ممكن يكون overriding aorta, يعني الاورتا بس sitting on top of the interventricular septum بدل ما تكون على الجهه الشمال منه في النص فوقه. السيفير elements ممكن يقول لك double outlet right ventricle, يعني الرايت ventricle سوري الايورتا عديل للجهه اليمين, فبقى الرايت ventricle عنده two outflow tracks, البلمونري artery والايورتا. So what happens during anesthesia? So with all sorts of anesthetic inductions, you invariably drop your cardiac output a little bit and you drop your SVR, especially in this classic scenario where it's an IV induction, you've given IV fentanyl, a good dose of IV propofol, and these two together in a small infant, you would have dropped the cardiac output and the SVR, and therefore the systemic blood pressure would have fallen. طيب, on the other hand, المريض has زي ما قلنا RV outflow tract obstruction, والسبب بتاعه انه الاوتفلو تراك ده في عضله حوله اسمها الانفانديبيولار ماسل. الانفانديبيولم ده is a very يعني اقول لك شنو sensitive muscle. فوات happens if there is any kind of stimulation، يعني البيبي ده انت رقدته خدرته intubated everything، جات النيرس رفعت ظهره دايره تحط الدايثيرمي باد، ولا السيرجن trying to catheterize، ولا whatever is happening. If the patient is not deep enough, this patient will have a sympathetic trigger, and this sympathetic trigger will release systemic catecholamines. A systemic catecholamines will reach the heart and specifically act on the infundibulum and cause a muscle spasm. عشان كده بنسميها infundibular muscle spasm. And then what happens after that is an outflow tract gets even tighter on the right side, and the blood flow, the pulmonary blood flow is reduced. The RV chamber systolic pressures rise, and then the blood flow across the shunt, across the VSD, swaps from going left to right, بيمشي right to left. ليه بيحصل الريفرسال ان ذا شنت فلو؟ لانه قلنا قبل الانستيجيا دراجز بتاعتك already cause systemic hypotension، فالبريشر on the left side the LV pressures are low. في نفس الوقت البيبي حصل له sympathetic trigger infundibular muscle spasm، ال RV pressures زادت to a point where they become supra systemic، فبيحصل طوالي reversal in the shunt. Deoxygenated blood, which is mainly on the right side of the heart, crosses the VSD and mixes with the oxygenated blood on the left side of the ventricle. And then what you are measuring in your SATS probe is actually this increased mixing of blood, and therefore the saturations drop. So what happens? How do we treat it now that we understand the physiology? And like I said in the second point, hypoxemia, which is refractory to FiO2, to oxygen delivery. يعني الحالة دي even if you increase the FiO2, the saturations came up من 55 ل 65. يعني they did not completely resolve the problem. لأنه like I said, this is primarily an intracardiac shunt problem. It's not an oxygenation problem. The way to fix it is to reverse the intracardiac shunt, and the way we reverse the intracardiac shunt is by يعني fixing the causes of it اللي هم حاجتين. A systemic hypotension, we need to fix that, and we fix that by giving a vasopressor, and this vasopressor is primarily phenylephrine لأنه it's titratable, it's consistent, is fast acting. The other side, we need to drop the RV systolic pressures. We want to relax the infundibular spasm, muscle spasm. And how do we do that? Is by mitigating catecholamine surge by stopping this sympathetic trigger. How do we do that? We need to deepen the anesthetic. When you deepen the anesthetic, when you deepen the anesthetic, you want to carefully choose the drug for that. You do not want to give a drug that will cause the SVR to drop even more. Here is fentanyl or even ketamine. الحالتين they work fine, equally well. I prefer fentanyl, and it's again very quick, very rapid. And very quickly after that, you start to see that the saturations have improved. The shunt has reversed back from right to left. Now it's left to right, and everything is okay. So some people give fluids in this scenario as well. That's okay. Lakin what you have to understand, if you really understand the physiology, this patient is not hypovolemic per se. يعني انت you haven't just taken volume out of the child. The patient's volume status is the same as it has been pre-op. What has happened there is some physiological changes that happen within the heart that cause a reversal in shunt across the VSD. So yes, you can give volume, but that alone does not really fix the problem. Like, how can you try and sort of risk stratify the next tetralogy of fellow that you see on your list next time you do a pediatric anesthesia list, if it is an unrepaired tetralogy of fellow? So, يعني, this starts in the preoperative phase. You have to, having seen the patient, you have to review their latest echo findings, and that tells you an indication of how severe their underlying cardiac diseases. Like I said, some tetralogies are much easier and much better than other tetralogies. In fact, we call them in the cardiac world, we call them pink fellows. Pink fellows or blue fellows. And pink fellows there, they do not have as severe a disease, and usually they don't cause you problems. Like in blue fellows, especially the really cyanotic children, they tend to be very tricky and very difficult. Well, the way you can figure that out is by, first of all, looking at the echo. The echo will tell you if the heart has an increased RV wall thickness. That means the outflow tract is very, very stenosed, very tight. If the VSD is big, the bigger the VSD, the more likely you will have mixing. And if you have mixing, then the more likely you will desaturate quicker. You can also look at the size of the pulmonary valve and the outflow tract. Sometimes the cardiologist will give you what we call a Z score. So they look at the body surface area and they calculate the size of the outflow tract. And if the Z score is -2, -3, then that means it's very, very, very tight. Also, in subhanallah, in very severe fellows, because they are so bad, then the body tries to find other pulmonary blood sources. So they, over time, they develop what is called a MAPCAS. ومابكس اختصار لمultiple aortopulmonary collateral arteries. فالمريض then starts to vascularize. Pulmonary arteries are getting now blood directly from the aorta through collaterals. And these supply the pulmonary blood flow to the lungs, and therefore they maintain the saturations. فناw في الحالة دي pulmonary blood flow is not just only dependent on antegrade blood flow اللي هو طالع through the right ventricle and through the pulmonary valve. لا, the other source of pulmonary blood flow coming directly from the aorta through small snake-like collaterals coming from the descending the arch and going straight into the lung parenchyma. Seeing a lot of MAPCAS is severe outflow tract obstruction, لكن at the same time they are helpful لأنه whatever happens, if you get an infundibular spasm, if you get a severe outflow tract obstruction for any reason, أنت عارف إنه as long as you maintain your systemic blood pressure, then there will be blood flow coming in through these MAPCAS to supply the lungs, and your saturations will be maintained. Also discuss with the cardiologist how worried they are about the patients. If you see that the cardiologist started the child on preoperative propranolol, again, that's a risk indicator, a red flag that this child was actually quite severe in the pre-op state. If you see that the patient's hemoglobin count is very high, they are severely polycythemic, then that again is an indicator of chronic severe cyanosis. And sometimes in these cases, you can see hemoglobin of 220, 180, 220, 200, very high levels. And that indicates severe hypoxemia and a severe risk of further desaturation. And in these cases, you have to prepare from advance. Your anesthetic plan actually starts not just in the intraoperative phase, even in the preoperative phase. How? By pre-operative optimizing this child in terms of getting IV access, minimizing their fasting times, keeping them very well hydrated, making sure that they are on pre-operative beta blockers. And by the time they come to the OR, they are in a good shape. They are in the best place possible. Sometimes you can even consider giving a pre-med. If you give a pre-med, you can give here a very elegant and clean drug. It does, at the same time, it can act as an anesthetic sparing technique, because if the child comes already sedated on some dexmedetomidine ولا حتى clonidine, then what happens is you do not need to use as much sevoflurane. You do not need to use as much IV propofol. So that means you do not impact the hemodynamics as much. فدي كلها techniques you can use to try and make your life easier. So in practice, what we will do, again, the ABCD approach, we discuss supporting the circulation, stopping the sympathetic surge. So if the surgeon is starting to position the child, turning them, trying to catheterize, you have to tell them to stop. And this will hopefully reduce the trigger. Optimize your oxygenation. Obviously, go up on your FiO2, but this is not the real solution. It just helps to buy you more time. Deepen the anesthetic. My choice is fentanyl. You can use ketamine if you prefer. Give vasopressors. The key thing here is vasopressors. You need to push up the SVR to reverse the shunt from right to left to make it left to right again. If you do not have access to a vasopressor, good vasopressors are things like phenylephrine. Once you start using things like ephedrine, they don't really get you what you want quickly and effectively. So the books describe, putting them on a knee chest position, and I tried it once and it actually works. It's not really something that you can rely on. So have a good vasopressor case, diluted, ready, pre-drawn. We discussed the utility of giving IV fluid bolus. It's not the real solution. It may help. And like I said, consider pre-operative beta blockade. If they're not already on it, then it's difficult to really start it in the middle of an acute phase. If you have access to some fast-acting, fast onset and fast offset beta blockers like esmolol, they can sometimes help as well. We use it sometimes in critical care for these children. And if they are then stabilized, then just give them a few minutes, make sure they're all behaving well and consistently well, then you can proceed. However, if they are unstable, it's reasonable to then abort the surgery and to either take them to critical or wake them up. So this is my final slide. I just thought I would include some other random emergencies that are commonly seen by pediatric anesthesiologists around the world. I'm not going to discuss them at length, just keep them at the back of your mind. One of the most scariest experiences I've had, I once anesthetized a child and they had a perfect, in my mind, what I thought was a fantastic anesthetic. Everything went smooth, easy. There were no issues. Extubated the child. They were comfortable in recovery and going back to the ward. Just before down the second case, the red buzzer, an emergency alarm went off, and we immediately realized this is coming from the recovery room, and we rushed there to see it was my patient. When I saw it was my patient, I thought, what on earth just happened? What is going on? This child was perfectly well 10 minutes ago. And the child had a respiratory arrest. They were bagging him. One of my other anesthetic colleagues was about to intubate. And I was trying to think, what on earth happened? And people were asking me, what drugs did you use? Were there any problems? And then later on, so the child was intubated, and then very quickly we realized exactly what happened. What happened was that there was residual rocuronium in the needle, in the octopus, in the giving set. So we put 2 IV lines for this kit. One was the one we used for induction, a very small 24 gauge, and then we used the bigger line for volume on the other hand. The volume line was obviously being flushed with fluids and IV maintenance, but the other line that we put initially for the induction that had rocuronium in it, we forgot to flush it at the end. and this residual in the cannula. So when the patient was ready to go to the ward, the nurse flushed the line to wrap it in a dressing before the patient went up in a bandage, and then the patient arrested. So again, I'm bringing up this scenario because it can very easily happen. So please make sure you flush all your lines before you transfer your child from the OR to the recovery room, and this can make you avoid some major problems. Also, this issue of latex allergy, in most modern ORs, latex has actually been removed completely. Like in some developing world scenarios, you may find that latex is still the primary material used with spina bifida or myelomeningocele, any things of that nature. Just keep in mind the incidence of latex allergy is fairly high in these children. Keep it at the back of your mind. Make sure that latex is removed from the OR and that the OR is cleaned, so that you avoid being in a scenario where the child develops a latex hypersensitivity reaction in the middle of the case. It might not happen immediately, like it may happen as the case is progressing, as the child is getting more and more exposed to the latex antigens. Again, something to keep an eye on. It's one of these sort of associations that are mentioned a lot in pediatric anesthesia textbooks: spina bifida children and latex allergy. And finally, malignant hyperthermia or hyperpyrexia is again a very rare occurrence. Lakin we see more of it in pediatric anesthesia than you do in adult anesthesia, because that's when people generally present for their very first anesthetic in their life. It tends to happen most often in childhood, and there may be some family history, there may not be, but it's again like local anesthetic systemic toxicity. If you don't think about it, you will not recognize it. I was recently on a mission to do cardiac anesthesia in India, and we had a case that we suspect was malignant hyperthermia, and later on it materialized that the child's uncle had a similar event. So in those scenarios, if you're faced with a case where there is an unexplained rise in temperature, the patient is hyperpyrexic for no real reason, and especially if it's difficult to cool down, if there is signs of hemodynamic instability, rising heart rate, dropping blood pressure, if your end-tidal CO2 is really high or continuing to rise, and especially if you progressively see signs of rigidity, primarily chest wall rigidity, reducing lung compliance, higher airway pressures, then you have to think about malignant hyperthermia. And in those scenarios, obviously, you remove the trigger. It could be simply the volatile anesthetic. It could be drugs. Whatever the cause, you have to stop it, and you have to continue supporting the patient. The primary treatment is dantrolene. You may have access to it. If you have, great, use it. If you do not, at least try the simple supportive measures, and most importantly, remove the trigger. And that's all there is really to say about that. So in summary, this is really all I wanted to discuss. I hope it's been a good presentation. I hope it's been interactive. Thank you all very much for being involved. I'm really encouraged and very happy with the quality of the answers. Clearly, a lot of you do pediatric anesthesia or you are interested in it, and there is a good level of awareness about pathology and the common emergencies that you can face as a pediatric anesthesiologist. So again, thank you for taking part, and I'm happy to discuss any quick questions if you have it. Thank you.
Thank you very much, Mohammed. Again, very informative and rich sessions. I will just read what I have received in the chat box So in cases of local anesthesia toxicity, systemic toxicity in pediatrics, if cardiac arrest occurs, do we follow the same ACLS protocol as in adult with a reduced dose of adrenaline or epinephrine?
So in local anesthetic systemic toxicity, if you are in a cardiac arrest scenario, you follow the pediatric advanced life support algorithm. And your primary aim here is to achieve ROSC. To achieve ROSC, you need to use epi. There is no point using a lower dose of epi because you're worried about the underlying broad complex or arrhythmogenic problems that you face with the local anesthetic toxicity. Your primary priority here is to return ROSC as soon as possible. So I would discourage you from reducing the dose of epi. Use the correct dose of epi. But in the meantime, give intralipid. So, you know, in a pulse algorithm, you have to recognize the cause for pulse. You know, you're thinking about the 4H's, the 4T's. One of the 4T's is toxicity. What is the toxicity cause here? It's local anesthetic. So what is the treatment for local anesthetic toxicity? It's intralipid. So you do not necessarily modify your pulse algorithm doses, whether it's epi, whether it's amiodarone, whatever. You use exactly the same doses as per the protocol, but you have to also give the antidote for the cause of the arrest. And
Yeah,
that's it.
I guess the question, yeah, Mohammed, whether he would give a reduced adult dose. So the answer clearly, you should follow the pulse recommendations and algorithms here. Here, another question, yeah, Mohammed, they're asking you about your experience with Dexmed in pediatrics anesthesia.
Yeah, Dexmed is a wonderful drug. It's not a perfect drug, but it's actually a very versatile, very flexible agent. So Dexmed can be used as a pre-med. It can be used as an intraoperative anesthetic maintenance IV drug. And it can be used post-op as well as an ongoing sedative, whether it's in the intensive care unit or even sometimes in PACU, in children who you do not want them to wake up quickly and be unsettled. For example, in cardiac cath labs, we usually anesthetize these children for very complex, interventional techniques. We use big sheath. We put arterial and femoral venous sheath, and we do not these children to wake up and be, very mobile and agitated. So we sometimes run a Dexmed infusion, a low dose Dexmed infusion in recovery for the first hour or so until we make sure we have good hemostasis at the cannulation sites. And we've done a post-operative echo to make sure the stent or the device closure that we just implanted hasn't displaced or caused any problem. So it has pre-operative, pre-medication uses, it has intraoperative, and it has post-operative uses. Dexmed can be given both as an IV, as an oral, and as an intranasal drug as well. So the usual technique, mode of administration for pre-med is actually intranasal. So we give, and it's usually as a rescue intranasal technique. So children who are, it's extremely difficult, children who have severe learning disabilities, ADHD, autism spectrum disorder, who sometimes may be quite difficult to be brought to the anesthetic room and have a standard gas induction. They may sometimes even refuse to take an oral pre-med or even spit it out. So in these cases, we can administer a quick intranasal drug, and usually dexmedetomidine is very effective. So I'm a big fan of it. But I think when it comes to pediatric anesthesia, the real value that dexmedetomidine gave to me in my practice is an anesthetic sparing drug. When I am treating cardiac patients, I really do not want to give them the standard doses of anesthetic drugs that are used for the general anesthesia patients. If I use the same approach, I might have a lot of problems with hemodynamic instability, with unnecessary fluid voluses, blah blah blah. So I tend to use dexmedetomidine as an anesthetic drug primarily to help me reduce the amount of volatile and IV sedatives, hypnotics that I give. So I love it. I'm a big fan of it. It's expensive. It may not be available in all countries. Clonidine is its sister drug. It's not as clean. It's not as precise as dexmedetomidine. However, I also use clonidine as before, and it can be useful as well.
Thank you very much, Mohammed. By this, we conclude our session today on the overview, case scenario, and the overview on pediatric emergencies and resuscitation. We can stop the recording now. Thank you.